Welcome to our section on cardiovascular pathology in our USMLE and COMLEX Radiology Review Series. In this module, we're going to be briefly exploring normal cardiac anatomy in radiological imaging. The best way to approach image interpretation is to remember what you saw in the cadaver lab and to correlate imaging findings with a 3D model that you're holding in your head. So to help us do that, let's do a brief refresher of some of the anatomy within the chest. We have the trachea that goes behind some of the vasculature and breaks into the left bronchus and right bronchus. You can see the brachiocephalic veins coming into the superior vena cava. And right here you can kind of see a little bit of blue for the inferior vena cava coming up into the right atrium. There is also the right ventricle. These are both the anterior structures of the heart. Behind the right ventricle is the left ventricle, and the left atrium is in the back over here. Out of the left outflow tract from the left ventricle, we will exit the aortic valve and go into the aortic arch, coming back down behind the heart as the descending aorta. This is a normal chest X-ray of a healthy woman. You can tell that it's a PA view as the scapulae are laterally retracted on both sides and open up the view of the lung fields here. The R reminds us that this side is the right side, so you can think of it as the patient facing you. So with the 3D model from our previous slide fresh in our minds, let's orient ourselves a little. We have the vertebrae of the spine going down the center. There are the clavicles and the scapulae, and you can see the heads of the humerus as well. There are ribs curving down on both sides. There is soft tissue all around. Sometimes you have to check that for air that is trapped under the surface. There are obviously the lungs themselves, and you can see a little bit of hyperdensity in these areas that is from breast shadowing, which is important because sometimes that can be confused for pneumonia, particularly when a patient has had a one-sided mastectomy. The trachea is this more lucent portion, and it splits into the left bronchus and right bronchus. There's obviously the heart and the vasculature. Down here, the line at the top of the more dense area of the X-ray is the diaphragm itself, and where it meets with the chest walls, it forms these acute angles known as the costophrenic angles, which are important to investigate when considering different kinds of pulmonary pathology, which we will talk about in a different module. You can see the gastric bubble, which is indicative of the top of the stomach. And then in this area here, all of this is where the liver lives. Looking more specifically at the heart, right next to the vertebrae of the spine, you can see this more dense area. It's not part of the lung, and it's not part of the spine. That is the superior vena cava coming down. And right here, more of a dense area coming up is the inferior vena cava. There is the aortic knob, and it goes down into the descending aorta, passing behind the heart and in front of the spine. All of this here is pulmonary vasculature, and you can see the pulmonary veins and pulmonary arteries coming in and out of the heart. This would be the right atrium, the right ventricle. Behind the right ventricle is the left ventricle and the left atrium in the posterior aspect of the heart. As I mentioned earlier with the aortic knob, you have the blood from the left ventricle going out the left outflow tract, wrapping around the aortic arch, and then coming down the descending aorta. The final point to make with this image image concerns the size of the heart itself, something we call the cardiothoracic ratio. Now we'll discuss this in more detail in a later module in this section, but cardiomegaly, that is enlarged heart, is a sign of pathology in the heart. Now when do we call cardiomegaly? Normal is less than 50% of the cardiothoracic window. We get that by looking at the widest aspect of the heart and compare it relative to the widest aspect of the thoracic window. When this is larger than 50% of the thoracic window, then we start to be concerned about ventricular enlargement and cardiomegaly. This is an axial CT of the chest with contrast in a soft tissue window. As we mentioned before, it's important for us to keep in mind the 3D image that we put together of what we saw in the cadaver lab. This will help us make sense of what we see in the CT images, because we're essentially looking at layer upon layer individual images to help form a 3D image in our mind. So if we can compare that to what we already know from the cadaver lab, then we'll be helped in identifying both normal structure as well as deviations from the normal structure that we would expect to see. Just to orient ourselves a little bit, this is the back of the patient, and this is the anterior side of the patient. When we're looking at axial images, whether we're talking about CTs or MRIs, we have a common direction that we expect our patients to be. It's as if we're standing at the foot of the bed. The feet are coming out of the screen towards us. The reason that's important is because of that makes this side of the patient the right side and this side of the patient the left side. In this particular slice, you can see the heart on the left side of the patient, as we would expect. Looking at the bony structures, as I mentioned, this is the back of the patient. We see the vertebral bodies of the spine as we move through the images, and we can see the sternum on the anterior aspect. Moving around the thoracic wall, we can see multiple ribs on any given slice. This isn't one rib that we can see skipping of, but this is a rib, a rib, a rib. You have to remember that the ribs have a downward trajectory as it moves anteriorly towards the sternum, and because of that, any given slice, instead of catching an entire rib, will catch portions of that rib. These are the scapulae, and you can see soft tissue around as well, and it's in fairly decent detail given that this is a soft tissue window for CT. Within the thorax itself, if we move superiorly to the base of the neck, we can see the trachea and follow it down. It'll split into the left bronchus and right bronchus and will disappear into the lung. Again, these are the lung fields, the left lung and the right lung. We can see pulmonary vasculature, but in the soft tissue window, we're not going to really see a whole lot more than that. Moving superiorly again, we can see a little bit of a hypodensity. That is the esophagus. It isn't uncommon for the esophagus to disappear to some degree as you move behind the heart, but in this case it does open back up with another air bubble just prior to going down through the diaphragm, which we can see a good deal of the diaphragm at the bottom of this study here. Of course, the main thing that we're here to see in this section is the heart itself, and superior to the heart, the great vessels of the heart. Now, when considering the structure of the heart, I personally find it easiest to think about it as the blood flow moves through the structure, and that'll help me review what there is to see. So these structures here are the left and right jugular veins. We're going to go with the left jugular vein because, as you see, as you move down, the right jugular vein winds up being obscured and we can't follow it as well. This is the left carotid artery, common carotid, as well as the right common carotid. Following this left jugular vein inferiorly, it connects with the left brachiocephalic vein, which connects with the right brachiocephalic vein to form the superior vena cava. This descends past the great vessels and empties into the right atrium, as does the inferior vena cava from inferior position. The right atrium then empties into the right ventricle, which is the anterior-most structure of the heart. It passes by the tricuspid valve in order to do that. And then coming out of the right outflow tract, we pass by the pulmonary valve and move superiorly into the pulmonary arteries with deoxygenated blood. This blood then goes through the lungs and comes back into circulation inferior to the pulmonary arteries in the pulmonary veins, and we can see that on both sides, and empties into the left atrium. This oxygenated blood then continues through the mitral valve into the left ventricle, where it is squeezed out through the aortic valve and into the ascending aorta. It continues superiorly above the other vessels and forms the aortic arch. Remember that at this point there are other vessels that take blood to the limbs and the head. And the aorta continues inferiorly as the descending aorta. Some other structures that are important. As I pointed out, this is the right ventricle and left ventricle. In between those, there is the interventricular septum, as well as you can make out the left ventricular wall. There are other structures that we'll review in CTA as well. Now, of course, in examinations, you're unlikely to get a scrollable image like this. That would be really handy and, in my opinion, much more realistic, as that's what you see on the wards. But it is what it is. You're likely to get one static image that you need to make either a normal diagnosis or a pathological diagnosis from. So it's important for you to be able to identify common structures in the most commonly used views. And that's what we're going to look at next. Okay, this is one of the 6 commonly tested views that you can wind up seeing on CT imaging for the heart. Where would you think that we are in the heart right now? This is called the 5-vessel view. It is superior to the heart and inferior to the base of the neck. You can obviously make out the lung windows here. This is the trachea, and this little black dot is the esophagus. The 5 vessels that the name of the view is referring to is the left and right brachiocephalic veins. If I move from the view, you can see that these merge together to form the superior vena cava. And returning to the view, you have these 3 vessels right here as well. All 3 of these come off of the aortic arch. This vessel being the innominate artery, the left common carotid artery, and this winds up proving to be the left subclavian artery. The next view is at the aortic arch level, aptly named. You can see the aortic arch right here next to the trachea. This structure is the superior vena cava, and if we move inferiorly, you can see it come together with the right atrium. Back to our image, we have the azygos vein wrapping around the trachea and emptying into the superior vena cava. And then you can still see a little bit of the esophagus as well. Continuing to move inferiorly, we can see the aortic arch turn into the ascending aorta and the descending aorta. The descending aorta is always posterior in the thorax. This is the superior vena cava still, trachea, and we no longer have that bubble in the esophagus, but it is likely there. We're starting to see a density right here, and if we are to go inferiorly, then we can tell this is from the pulmonary arteries, the main pulmonary branching into the left and right. But at this point, superiorly, we can still see the section under the aortic arch, but above the pulmonary artery, known as the aortopulmonary window. Continuing inferiorly, we are at the main pulmonary artery level. We can see the main pulmonary artery here branching into the left and right pulmonary arteries. There is the ascending aorta as well as the superior vena cava. At this level, you can also see the left and right bronchi and the descending aorta. At this point, we've descended low enough that we can start to see the structure of the heart itself. This is the high cardiac level, and we can see the pulmonary veins spilling into the left atrium, the most posterior structure in the heart. On this aspect is the right atrium. Over here, we get the left ventricle and the aortic root. And up here we get the right ventricular outflow tract. Now there's an important relationship between the right ventricular outflow tract and the aortic root. Outside of certain cardiac abnormalities, the pulmonary valve is supposed to be anterior, lateral, and superior to the aortic root. The acronym is PALS, P-A-L-S. Pulmonary, anterior, lateral, superior. And as I have already said, when this anatomical relationship isn't seen, then it might be reason to suspect some sort of cardiac anomaly. Finally, down in the low cardiac level, we can see this entire area here is the left ventricle, the right ventricle. This is the tricuspid valve, making this the right atrium. You can also incidentally see the coronary sinus wrapping around the left ventricle here. This is the descending aorta and the esophagus. It's also important to note the intraventricular septum or interventricular septum, the left ventricular wall, and that makes this structure, this left ventricle, more of a tubular structure, while the right ventricle wraps around that tubular structure. This is the right ventricular wall. There are a couple things to note about it. One, it is thinner than the left ventricular wall, as the left ventricle is the powerhouse to push the blood throughout the systemic circulation. Secondly, we can see all of these lines, these darker areas throughout the right ventricle. That's because the right ventricle is more heavily trabeculated than the left ventricle. In addition to CT imaging, we also can provide MRI imaging, which provides many advantages that we'll get into as we encounter relevant pathology in later modules. But regarding normal anatomy, MRI has the added benefit of not only getting the standard axial, sagittal, and coronal views, but it can also generate images on other user-defined axes, which can tell us about the function of the heart. The first view in the upper left, the vertical long axis view, in it we can see the left ventricle, the left atrium, the pulmonary artery, and the aorta, as well as the mitral valve. This view is primarily used to assess left ventricular anterior and inferior walls, as well as the apex. This second image is the horizontal long axis or four-chamber view. It allows for the visualization and inspection of all four heart chambers, as well as the musculature around them and in between them. Between the atria and the ventricles, we can also see the tricuspid and mitral valves, which we can then assess for patency. In the top right, we have the 3-chamber view, which gives us a clear view of the left atrium and the mitral valve, the left ventricle and the left ventricular outflow tract, as well as the aortic valve and the aorta. Finally, in the bottom right, there's the short axis view, with which we can not only assess the walls of the left ventricle and the right ventricle, but the MRI software can use the measurements that it has to calculate the stroke volume and ejection fraction without the need for intervention. These are a selection of some of the views that you can get with an echocardiogram, which is an ultrasound of the heart. There are multiple ways to perform this exam, including visualization between the ribs for transthoracic echocardiogram, or TTE, or sedating the patient and inserting a transducer down their esophagus for transesophageal echocardiogram, or TEE. In addition to the anatomy, the rater can also use color Doppler to help assess cardiac function. Now, an ultrasound tends to be a more advanced technique, so it's unlikely you'll need to know even all that's on this slide. If anything, pay attention to the 4-chamber views as well as the short axis views, which are very similar to what we saw in the previous MRI slide. For our last topic in this module, we should briefly refresh our memories on the coronary arteries. In the aortic root in the right and left coronary cusps, there are dilations in the root that give rise to the coronary arteries. Unlike in systemic circulation, the coronary arteries receive blood flow during diastole, as blood is unable to flow through the myocardium when the ventricles are contracted. Systole then serves to push blood towards the cardiac sinuses. In this image, you can see the primary vessels of the coronary arteries. The right coronary artery and its divisions continue down the anterior side of the heart, branching first into the acute marginal artery. The part of the right coronary that goes inferior branches off to the branch of the AV node, as well as the posterior descending artery towards the apex. The left main coronary artery quickly branches after leaving the aortic root into the left circumflex artery, with the marginal arteries coming off of it, and the left anterior descending artery, with the diagonal branches coming off. This continues down to the apex of the heart. Another interesting note of importance is that not all hearts have the same pattern of coronary arteries, and sometimes you can receive questions about this. In the last slide, what we were actually talking about was the right dominant structure of the coronary arteries, which about 85% of the populace has. In this image, you can see not only the left anterior descending artery and the left circumflex artery coming off of the left main, but the RCA coming down the anterior side of the heart, wrapping around to the inferior portion, and branching off is the posterior descending artery. It is this PDA that determines what is the dominant vessel. Since the PDA in this particular structure came off of the RCA, that makes this a right dominant structure. Another alternative is left dominant, which about 8% of the population has. In this, the RCA does not ultimately terminate in the PDA, but instead the left main branches into the LCX and LAD, and one of these two vessels will be the one that supplies that PDA, or the inferior septum. In this particular image, they have the LCX wrapping around and forming the PDA, but it is also possible for the LAD to not only reach the apex, but to loop around and supply the PDA's area that way. Codominant, about 7% of the population, is simply a mixture of the two. This particular image has the RCA wrapping around as well as the LCX wrapping around, and both supplying the area of the PDA. However, it could also be a situation where the LAD wraps around and joins in with the RCA's terminal PDA branch to supply that area instead. While I was thankful to know the answer to this when I was pimped on my interventional cardiology rotation, it's honestly unlikely you'll see more than possibly one question involving digital subtraction and geography on your exam, so I'll make this brief. What we have here in the top left is that right dominant circulation that we were talking about. This is the RCA coming around. You see the loop being on the left and supplying this long portion, which winds up being the PDA. Similarly, in the top right, we can see a structure that everything seems to be coming off on the left, almost like spider legs or crab legs. So we kind of get an idea that we're probably dealing with the left main coronary artery and its branches. In this particular branch, we can see the somewhat jagged turn of the LCX coming inferior to the heart and then coming forward as the PDA. As I mentioned in the previous slide, that isn't the only way to have a left dominance. You can also have this left anterior descending artery come all the way down to the apex, at which point it makes a sharp turn and supplies the PDA there. This concludes our module on normal cardiac anatomy.